All right, it's 8 o'clock. Should I get started?
Let's do it.
All right. How do I tell who's here?
If you click on participants and there's an attendee list.
All I see is you and Sarah Lynn and me. Oh,
So
attendee list. Okay. All
panelists,
right. All right. I'm looking at the wrong thing.
Yeah.
All right. Okay. I see Dr. Fitzgerald and Dr. Van Horn.
Mm-hmm.
All right. Okay. So I'm going to go ahead and get started. Again, thank you, Dr. Gupa. Thank you, Sarah Lynn, for setting this up. I'm sure you guys are all tired of doing Zoom lectures by now. And probably never want to do another one again after this is all over. But I think this has been great, and really want to applaud the efforts of everyone involved. So thank you so much. So I gave a talk on kind of zebras in pediatric otolaryngology that I've seen, just kind of a personal collection of strange files a couple of weeks ago, and then got asked to present this lecture on congenital nasal airway disorders. One of my favorite things to talk about and see. It's whenever we get that call from the NICU that there's a baby, they're trying to rule out choanal atresia, I kind of get a little bit excited because it's just going to be this fun kind of detective work to see what's going on. And you know, of course, most of the time you go and everything's fine and you can put the scope in and get all the way to the back and it's fine. But not infrequently, especially around it here in our experience, we find some interesting things. So it's kind of fun diagnostically to figure out what's going on, challenging, but then I really enjoy the treatment strategies of these things as well. So that's kind of what prompted me to kind of put this talk together and share some of our experience and talk about it. Of course, some of the residents here have heard my dad joke here about when you think it's a booger, but it's not. And certainly that's the case for many of these kids. So just some standard disclosures. I've got some images that are my own, stole some from the internet. textbooks, yada, yada. I'm not getting any financial reimbursement. Am I, Dr. Gupta, for this? Okay. All right. So just some objectives at the end of this presentation. My hope is that everyone will be able to kind of formulate in their minds a differential diagnosis for congenital nasal airway disorders. When you get that call from the NICU or the newborn nursery, or your pediatrician calls you, or whatever the case may be, and they're not sure what's going on with this baby and why this baby's grunting and snorting and this kind of stuff, just so you can have a framework in your mind to work through a diagnosis, a differential diagnosis plan, and apply appropriate diagnostic techniques. And then hopefully we'll be able to discuss some appropriate management strategies for some of these entities that we'll talk about. So you can't talk about congenital nasal disorders honestly without talking about embryology, everyone's favorite thing to talk about. But I do think if you have kind of at least a general concept for what's going on embryologically, then you can kind of get a sense for how the pathology is going to present, or what kind of pathology might be present. And to me, this is just so fascinating. We've got these 3 phases of embryologic nasal development, kind of this pre-skeletal phase. Then you've got some cartilage formation, then an ossification phase, and then you go from something that is unrecognizable to this looks like a baby within only about 10 weeks. So it's really, to me, it's just fascinating, all this migration of cells forming what they're going to form. And to me, it's just amazing that as much that has to happen, how often things form the way they're supposed to. So to me, that's just kind of a fascinating thing. Certainly looking at the external nasal development, kind of some prominent features that you'll see are these, you've got these nasal pits, along with the medial nasal prominence and lateral nasal prominence here that form laterally along with the maxillary prominence. And these things start to migrate medially. And certainly these medial nasal prominences will form in the middle to kind of form the dorsum of the nose, columella, and philtrum. And then these lateral prominences will form the ala. Of course, you have the maxillary prominences coming in, joining with these structures. And this middle structure also is going to be involved in forming the primary palate, as you can see on the lateral, or the sagittal view rather. So you've got formation kind of from that lateral to medial plane, but then there's kind of an anterior to posterior development of the nose as well, the invagination of the nasal pit, breakdown of that oronasal membrane to form a patent nasal cavity, and then you kind of get things coming from the side with that formation of the secondary palate and whatnot as everything kind of comes together. So lots of stuff happening in, frankly, a very, very short period of time, 10 weeks. And so it's just a fascinating process to me. So the other thing that's fascinating and relates to, kind of how these present is just the neonatal nasal physiology. I'm sure, as everybody knows, that newborn larynx will sit up higher relative to what our larynx is as an adult. That epiglottis will kind of just approximate that uvula and the palate, forming kind of a nasal airway, blocking off the mouth. And this kind of is very useful and essential to the swallowing and breathing physiology that newborn babies will have, just coordinating how they can suck and swallow and breathe all at the same time, which is a very difficult thing to do. But amazingly, this structure and function really allows for that to happen. So if there's any pathology, obviously, of the nose where you lose that nasal airway, you're going to have some sense that something's going on. So as you may remember, usually babies are obligate nasal breathers, so meaning they can only breathe through their nose up until about 6 months of age. Some people say up to 9 months, but you know, in general, that's kind of what I say is about 6 months of age. And if there's any sort of obstruction, pathology, whatever the case may be, associated with the nasal airway, there can be some problems. So this paradoxical respiratory distress syndrome, I just think is very, very fascinating. The whole idea that when the baby's crying, the baby's pink and breathing, but when the baby stops crying, we'll have some cyanosis and that kind of thing. So you get this cyclical cyanosis going on. And then obviously they need this to coordinate the suck, swallow, breathe. So the other thing is that these varying anomalies that we'll see will all present very similarly. These babies will have stuttor, grunting. Certainly they can have problems with latching and coordinating that suck, swallow. So they'll have dysphagia. They'll get the respiratory distress, as we discussed, and then also failure to thrive. So either by not adequately taking in calories because of you know that process being hindered, or sometimes they're working so hard to get those calories in that and to breathe that a lot of their calories from nutrition go into just trying to breathe and eat rather than into growing. So you get the failure to thrive. And then of course in severe cases you'll get cyanosis and desaturation, things like that. I put on here this picture of the 6 French suction catheter, because that's kind of your standard way, at least that people say will be to, at least that's what kind of usually the NICU will do, is they'll say, oh, we can't pass this 6 French catheter and whatnot. So it's certainly the first line of diagnostic evaluation. Certainly if things are more severe, you know, you do have to get some prompt recognition of this in order to manage this. We did have a nice Socratic discussion last time about this with the other baby that we presented. You know, is what's your pathway? What are you going to do to manage these babies with this? So, you know, certainly get an oral airway in, and which definitely helps. They can't breathe through their nose, so you got to get that oral airway in and allow them to breathe that way. A McGovern nipple, you know, is always presented for this as an option. And I've simply just, in the past, if need be, taken one of those pacifiers that the NICU has, cut the end off, and pop it in the baby's mouth. And usually that's not a permanent situation, but it can at least temporize. Obviously, you can intubate, and then if you need long-term definitive airway management, tracheostomy is certainly kind of the gold standard for that. So we talked about the indirect techniques of diagnosis using that 6 French catheter, seeing if there's fogging in front of a mirror. Those types of things are always described. But of course, you know, those aren't the things that we do. What we're looking for is we're looking for the fiber optic exam. So we are fortunate to have a setup similar to this that I've got pictured here, where we have an iPhone that connects to a camera that hooks up to our scope. And it's very nice to be able to record these, and that way, if I'm not available, or if we just want to look back at it later, we can review these and take a look at that. So I think that's very helpful. But of course, that's kind of the gold standard for us to figure out what's going on, to see if we can even pass the scope, which might suggest some anterior pathology, versus seeing if things narrow posteriorly suggests it's a posterior pathology. And then of course, imaging is important. If we're looking for a bony type of pathology, we're going to get CT with some maxillofacial sequences. If we're concerned about soft tissue involvement, intracranial involvement, then generally we add an MRI to our evaluation. So you know, people classify things a lot. And certainly lots of people, as you can see in this list, have classified nasal deformities. Whitaker in 1981 kind of came up with a little bit more of a systematic approach that was then approved by Losi in 2004. And then, you know, I don't know how helpful this is really, but other than just to know that, hey, guess what? Somebody classified this, and maybe it's one other thing you have to memorize for the test or something like that. But so there are these type 1 classifications, which kind of suggest hypoplasia or atrophy, you know, so agenesis, hypoplasia of certain structures that are involved in embryologic development. And then type 2 being hyperplasia or duplications, so multiple parts of things, hypertrophy of certain structures. And then type 3 would be clefts, which would include the Tessier clefts, series of facial clefting, frontonasal clefts, and cleft lip and palate. And then the type 4 classification are the neoplasms. Certainly, you know, infants can present with congenital nasal neoplasms. We have a baby on service right now that we're working up, that 12-day-old infant that has a nasopharyngeal mass that we just biopsied yesterday, and we're anxiously awaiting what the pathology is. But you know, you can certainly have benign neoplasms that can be involved, and malignant. This may be anyway. We'll see what happens here. But also vascular lesions can be present as well. We'll talk about some of those as we go through here. Congenital nasal anomalies in general, they're pretty uncommon. Just overall, you're going to see this probably in about 1 in 20,000 to 40,000 live births, which again, I think it's amazing, just considering everything that has to go right in order to not have one. And you know, amazingly enough, I think it looks like you're more likely to be struck by lightning in your lifetime than to have a nasal anomaly, but you know, certainly they're not as likely to be struck by a meteorite. But interesting statistics, it's only a 1 in 36 to be called down on The Price is Right. So I know that's something worth trying maybe someday. And then of course, winning the Powerball, 1 in 175 million. So probably not a chance of that, but certainly we see more congenital nasal anomalies than people winning Powerball. So the way I kind of like to look at this, just from my own kind of diagnostic approach and standpoint, how I think about these things, is I kind of divide up into kind of more of an external nasal pathology, things that would involve the external nose, the dorsum, kind of the frontal bone, those types of things, versus internal nasal pathology. And then I just kind of work my way back is what can happen anteriorly, what can happen in the middle, what can happen in the posterior nasal cavity, nasopharynx, and whatnot. And that's going to be how I'm going to just kind of order this lecture as we go through things here. So congenital vascular lesions certainly can occur anywhere along the nasal airway, but you'll very commonly see them in the nose, at the tip of the nose. We had an excellent lecture by Dr. Van Horn yesterday, who gave us a talk on infantile hemangiomas and approach to those. And this is one of the ones that I was talking to him about. This young child had, I think he's 3 or 4 in this picture, but you know, he had this nasal tip hemangioma that really was kind of more of the columella. And you know, this is something that his pediatrician told him, you know, this is going to go away and involute and that kind of stuff. And certainly it had involuted some, but I mean, of course, this thing is just basically a big tissue expander that expands the soft tissue there and stretches out the skin. And you know, even though it does involute, there's always just some residual that's going to cause either some cosmetic or even a functional deformity here. I mean, as you can see, it's this kid's nostrils, they're narrowed somewhat. I mean, he's doing fine, but this kid's about to start school. You know, there's self-awareness that Dr. Van Horn pointed out yesterday that that these children are having even by 3 years of age. And so it's important to address these things, at least by this age, I would say, if not sooner, just for many, you know, cosmetic, functional, and psychosocial type of reasons. So we can have different types of vascular lesions, you know, the neoplasms, which are the infantile hemangiomas, versus sometimes you can get vascular malformations here. Just reviewing, you know, the infantile hemangioma is the most common benign tumor of infancy. There are controversial several thoughts on how these are formed that I'm not going to go into. Certainly we can have isolated versus segmental. People talk about superficial versus deep. And then in general, as you know, we've got this rapid proliferation stage through the first 6 months of age, and then they kind of start to slow down by about a year, and then they involute over time there, usually about 10% for every year past a year of age. So options for this: observation, medical management. You know, the old standby was steroids, either systemic or intralesional injection. But of course, in recent times, we've just, you know, serendipitously was found out that we can treat these things with propranolol. So a lot of kids get put on propranolol for this. And it's, you know, a fairly well tolerated drug in kids, and they do well. Certainly for functional issues that you know, you can certainly try this out prior to jumping to surgery. And you can kind of reserve surgery for functional disturbances that are not treated medically, or for post-involutional scarring and redundancy and whatnot. So this is an article I like to look at every time we think about treating someone for with propranolol for the infantile hemangiomas. And oops, you know, I think some of these things have relaxed at this time. You know, there used to be this thought about, oh, you got to get these kids inpatient because you have this, you know, chance for EKG abnormalities, and they're going to get some hypoglycemia, and you got to watch them fairly closely. So, you know, I don't think people follow this exactly anymore with the inpatient type of initiation, but you know, certainly these are things that you want to be mindful of as far as especially with the hypoglycemia. So you definitely want to have children take this medication with their feedings, and watch that closely. But generally it's a 1 mg per kg per day divided twice daily, and you can, you know, adjust as needed, kind of titrate to effect for this protocol. So this kid went ahead and did a kind of a rhinoplasty approach to take off this this lesion, and he may not seem very happy, but his parents were pleased, and you know, hopefully less being made fun of and whatnot going to school, and so overall good situation. So, you know, you can see these things at the tip, but also I've seen these things just kind of right within the nasal ala. This is an infant that presented at a few months of age that started having some difficulties feeding, some worsening sturdor, and nasal congestion, and saw this baby and saw this fullness just right here within the nose. Got some imaging here to look at the soft tissue, and sure enough, it looked like a little vascular malformation, or not vascular malformation, but a infantile hemangioma. And because this baby was having some functional issues, we elected to go ahead and address this. Oh, okay, I've got a video. There you go. You can see how we're blocking up, you know, nearly the entire left nasal cavity there, and or left yeah, anteriorly there of the nasal cavity. So elected to take this child back to the OR, basically raise a little flap of skin and mucosa, excise this thing. Amazingly enough, they come out fairly well in one piece, and you can generally get dissection around these things. Even with those large external ones, for some reason you always seem to be able to develop a plane. And even though it seems like this hemangioma is so, you know, interdigitated or whatever the case may be with the skin, you can generally find a plane and take care of them. So it's kind of nice. Certainly there can be some other venous malformations. This is very subtle. It's a kid that was a little bit older. There wasn't the history of, you know, this you know, capillary hemangioma or infantile hemangioma enlarging and proliferating and then shrinking. It's just kind of this slight asymmetry, bluish hue here to the nose. I don't have any imaging from this kid because this was someone I saw a long time ago, but we did have some imaging. It just looked like a little vascular malformation. So moving on to these midline nasal masses, that's kind of the second thing, or the next thing I want to talk about. Surgical intervention, we're talking here dermoids, gliomas, things like this that we'll go over. Imaging is very critical, in my opinion, on these, for these, and surgical correction is usually warranted. These things can have intracranial involvement, whether they're dermoids, gliomas, certainly if they're encephaloceles, they can have intracranial involvement. But here I like this picture. You can kind of see this, the foramen cecum, that can kind of give you a sense that there was something going on embryologically that where there's some kind of remnant here of the process that occurs, and we'll talk about that here in a second. Excuse me. All right. Oh, okay. So to me, this is interesting how these things seem to form. I mean, nobody knows exactly sure, but with these midline nasal masses here, between kind of the developing neural tissue, the dura, and then the skin, there's this prenasal space theory that that you can read about. And basically, in embryologic development, there's this close approximation of kind of the neural structures, endodermal and the ectodermal structures there that are developing. And you know, I kind of think of this as some kind of embryologic tug of war that's going on, where if the skin wins and pulls in some skin, then you get things like dermoids and whatnot that can track up. And then if things win on the dural side, then you can get things like encephaloceles, or, you know, if you get partial closure of that tract with a stalk, you know, you can get things like gliomas, which is just some neural tissue that kind of got trapped there. So for some reason, right there in the midline, there seems to be some kind of embryologic tug of war going on. Another picture showing that I think is good. And you can see dermoids anywhere along this pathway in the midline. They can be right here at the skin, associated with a little tuft of hair, usually is kind of the classic finding. I've seen them just right in the middle of the septum, and certainly you can see them intracranially as well. And cephaloceles, you know, again, they can be anywhere along this pathway. They can even come right up through a cleft in the frontal bone there, and then gliomas as well. This little baby is a baby with the dermoid that you can see, and it's the more common of the midline nasal masses. We kind of talked about some of these the embryology before, but these are generally firm when you see them. There's no transillumination like you can see with other things. And then again, you can have some hair or discharge. Sometimes these things can get infected, and that's how they can present with some cellulitis, soft tissue infection of the nose. And then about 45% of these can have some sort of intracranial connection, or up to the skull base there. This is a child, an older child that I saw, 17-year-old. He was a twin, and his twin did not have a dermoid, but he did. And he presented with this nasal pit that just kept getting inflamed and draining. And that was kind of the reason for coming to see me, with some intermittent headaches. And you can kind of see right here, we've got this structure here that's showing up on MRI that kind of leads up to the skull base, but there was no intracranial communication. There are several ways to approach these. You can go and do a direct incision right over the lesion, the dermoid. Certainly things are involved intracranially. You can do coronal approaches for that. This approach that we took was kind of a rhinoplasty approach, just to try to be as cosmetically favorable as possible. You can do kind of a lateral rhinotomy approach along with this, just to give yourself a little bit more exposure. But since this thing didn't track intracranially, we felt that we could do this rhinoplasty type approach to get up there. And basically we incised a small ellipse around the nasal dorsum where this thing was exiting the skin, and then did this, raised up the rhinoplasty flap here of the nose, and then followed this tract up. And you can see how it's kind of splaying the upper lateral cartilages here. And these things can commonly do that. It splayed that, and this thing went right up all the way to the cribriform. And I wish I had pictures of this, but we did get an endoscope and put it up there and just kind of follow this thing all the way up. And that was interesting to kind of follow that thing all the way up, but it didn't show any communication. Had to kind of reapproximate those upper lats, otherwise, you would have had this strange kind of coin slot deformity there. But this is him afterwards, and he was happy, and his twin brother still said that he was more handsome than he was. So, but I kind of left that debate for them. But a couple of good kids. Of course, if you see in this image, you've got something that tracks intracranially. Obviously, you're going to have to do a much more extensive approach, get neurosurgery involved, that kind of thing. So the glioma and the encephalocele, again, we talked about this a little bit already, but you can get encephaloceles that kind of directly go through a cleft in the frontal bone, through this kind of embryologic defect here, the fronticulus frontalis. You can also get some that track down into the nose anteriorly, just through the prenasal space there, just kind of anterior to the crista galli. And then again, depending on what kind of resorption happens, you can either get an encephalocele or a glioma at those sites. This is not a picture of mine, but just showing a glioma. Usually these aren't right midline, they're kind of slightly off midline, and there can still be a little connection with a stalk to the CSF. So generally you don't want to biopsy these without, or address these unless you get some kind of imaging. These are soft as compared to the dermoids, but still there's no translumination, pulsation, that type of thing that you would see in a encephalocele. Now, there can be intranasal gliomas too. Again, this is not my picture, but that is something. This is a child that we got this picture sent to us from someone that was working in Ghana, I believe, and we were trying to get the child here with one of our plastic surgeons and the neurosurgeons to address this, but for whatever reason it didn't work out. But you can see encephaloceles present this way, and with these, there's this bluish hue that with pulsations that you can see when kids are crying, or when they valsalva, this thing can enlarge, and that's kind of that Furstenberg sign or test that you can see with these. Certainly teratomas are something that you can see externally. I thought this was an interesting article that came out of, what was this, in Iran. But just a very interesting lesion coming out here at the front of the nose. Now, these teratomas, they're a true congenital neoplasm that consists of all three embryologic layers that are in them, and that's kind of how you diagnose these things too, pathologically. And really, they can occur anywhere along the nasal cavity. They can occur anteriorly. They can occur, back in the nasopharynx. Sometimes they can be associated with, failure of the palate, the secondary palate to develop, and those types of things. So, so that's something that you want to be aware of and have in your differential. See them present in infants too. But there is this risk of malignant transformation. So always something you got to be mindful of. Now, these things, you can diagnose them prenatally on ultrasounds. And, if you think there's going to be some significant airway involvement, it's probably something you want to, for this or for any sort of lesion like this, probably something you want to consider an exit procedure, which is where, of course, you're going to partially deliver the baby through a C-section, be able to establish the airway or address things, however you need to do that. So also there's some very strange, uncommon nasal deformities. Things, there's one here that I'm going to show you that I have seen, but there are others that, they're just very rare. It's more like winning the Powerball than it is, getting struck by lightning kind of thing. So Arrhynia, pretty uncommon. This is one of these hypoplastic classification, but it's exceedingly rare. Interestingly enough, the residents around here know that I kind of like history. In fact, one of the residents, Dr. Skylar Trott, got me interested in this as we had a long car ride to COSM one year. And, we didn't have much to talk about, so we listened to history podcasts. And anyway, this, interestingly, Arrhynia was reported on this ancient Babylonian tablet. So I thought that was fascinating. I don't know how they could read that, but that was just kind of an interesting thing that I found. And again, it's a failure of those invaginating nasal placodes that we saw in our embryology slides. And then they can have associated CNS defects. And, otherwise, usually, many kids can have very normal development. This is a kid out of the UK or Ireland, I can't remember exactly, somewhere in the British Isles. But this child was in the news and has Arrhynia, and she's obviously she had to get trached for her airway management. And she's undergoing kind of staged procedures to address that. Proboscis deformity. This is also pretty rare. Just kind of a very interesting type of pathology here, where that the medial nasal prominence, lateral nasal prominence just doesn't medialize all the way and form to the midline of the nose. And so you kind of get this, what's called a proboscis that can occur kind of here, usually just medial to the medial canthus, and usually associated with a blind nasal cavity as well. And this is one of my zebras that I presented last time I talked, and we didn't know what to do with this kid. This is what this kid looked like, and he had a septum. For those of you who didn't see that lecture, there was a septum that was kicked way over here, and we required intubation at birth. And so he had basically this nasal cavity was completely obstructed. The right nasal cavity was 99% obstructed, and we did a procedure where we did a sublabia approach and basically drilled away some of the deformed bony septum that was there, and then sutured his cartilaginous septum over to his orbital rim and put a stent in and gave him a nasal airway on one side. And because he basically has no nasal cavity on this side. And we avoided a trach in him, and he's now about 3 or 4 years of age. And we've got plans to see if we can address him cosmetically here with plastic surgery folks in the near future. But he's doing great. But I guess my whole point in this was this I'm thinking now, after a lot of research and whatnot, that this may be a form of proboscis deformity here, that, you know, it's not up near the medial canthus, but maybe it almost reached midline, but not quite. Excuse me. So you can also get duplication. That's one of the classifications, hyperplasia, type 2 classifications of loci that we discussed. And this is very rare. I mean, I've never seen this, but you know, there's a picture of this baby with it, and certainly you can have some choanal atresia, other atresia associated with it as well. So we're going to kind of move on. Let me see what our time looks like. Okay, we might not complete this whole lecture, but we're going to move on to the internal nasal pathology, and want to kind of focus on some of these anterior nasal cavity issues. And I'm just going to briefly mention this neonatal rhinitis. You know, it's kind of the great masquerader for things. So if you don't see anything anatomically, you just see some inflammation. You know, there are protocols for this. I'm not going to go through this too much because it's pretty straightforward. Basically, it's just something you want to think about. Okay, so this is interesting. So got this call from a pediatrician, and this is about a week or 2 week old baby, and the chief complaint was this baby's eyes are moving while she's breathing. So let me show you that. So has anybody seen this before? Probably not. I've never seen it before, but I'm just gonna play that again. But you know, with respirations, this baby's kind of nasal lacrimal duct is, you know, just insufflating and in and out. So we got some imaging. Kind of skipping some things because I don't want to spoil the surprise on what it was. But as you look here on this axial scan, you can see, anybody see what they see? So I don't even know if people can talk to me, so maybe I'm just talking and nobody can respond. But oh, something's flashing up here. Chat. Oh, how do I do that? Yes, good job. Awesome. Central mega incisor. All right. Oh. So yeah, central mega incisor. And then if you look closely here, you can see a very narrowed piriform aperture right here. And then this baby has these huge nasal lacrimal ducts, which I thought was very interesting too. So it's almost like there's preferential, you know, airflow through the nasal lacrimal ducts rather than through the nose, kind of as the path of least resistance. So piriform aperture stenosis, first described in 1989, used to be called anterior choanal stenosis or something like that. But basically you get overgrowth of those lateral nasal prominences, and then there's kind of fusion of the central palate there. And you know, this can be varying severity, where you can get children that just have some kind of mild nasal obstruction versus, you know, things can be fairly severe. And I like to show this. So normally, you know, the piriform aperture, it's this kind of pear-shaped, triangular shaped sort of opening within the skull. But with the piriform aperture stenosis, you get this, you know, this kind of more of a coin slot opening of the piriform aperture. And in general, if this is less than 11 millimeters, it's diagnostic. And usually, if they're less than 8, you know, sometimes you have to intervene. This entity can occur in isolation. just all by itself, but sometimes it can be associated with some midline cranial abnormalities. So you can get holoprosencephaly, you can get some pituitary abnormalities as well. So whenever we see this, and for some reason, the residents here are going to attest to this, we see a lot of them. I don't know why. And we seem to see 2 every spring or something like that. There was one, it was last April or 2 Aprils ago, we had 2 of these babies come into the NICU in the same week. So just very interesting. And there can be some associated genetic predisposition or abnormalities. One of the children that we saw when we had kind of 2 in the same week had a chromosome 13 microduplication or something like that. So certainly there can be some things associated. This baby is the baby that was breathing through her eye, and believe it or not, as much as I tried to say, hey, we probably should address this surgically, at least do a dilation, the family was very eager to avoid surgical treatment. And believe it or not, she was a twin as well. And her twin did not have this, but she did. And so I watched this baby very closely. We did a lot of Decadron drops in the nose, and whenever she got a cold, we put her on some neosynephrine drops and just kind of struggled along with her. But she actually ended up gaining weight, and she gained more weight than her twin sister did, which I thought was just amazing. So, so some of these that are more mild, even though if you're breathing through your nose, I don't know how that's necessarily mild, but you can get away sometimes with conservative management of these. And just in my experience, which hasn't been a long, lengthy experience. I mean, I've been doing this for about 10 years now, but just kind of in total. But even though it's not a long experience, I've seen a ton of these. I've seen like 1 to 2 a year since I've been doing this. So, and I haven't been at, huge medical centers, but for some reason we see it around here. So, but yeah, so I guess in my experience, what I was trying to say is if they make it out of the hospital, many times you can kind of treat them conservatively, but if they kind of make it, where they're not able to leave the NICU, they're requiring CPAP and whatnot, generally we're looking at doing some sort of intervention. So, so this is one of my favorite conversations that I had with one of the moms. I'm telling her about, what's going on, how the mid face is narrowed, the opening for the nose is narrowed, and your baby's, sometimes associated with some brain abnormalities and some pituitary dysfunction, have to be on, hormone replacement, and we're gonna have to look at those things, and then your baby's gonna have only 1 tooth in the middle, and we're gonna have to do surgery. So after all that, the biggest question was, my baby's only gonna have 1 front tooth, and so which I just found a little bit humorous, but I said yes. And then believe it or not, Tom Cruise, many of you may know, and if you don't know, he has a single central mega incisor. Certainly he's had some dental work, but if you look at him, right in the midline, he's got this 1 single tooth over here. Basically, they've built up this kind of lateral incisor to make it look more like a central incisor. Because if you look over here, I mean, here's his canine tooth here and here. So, so now my go-to line is, well, Tom Cruise has the same thing. So, and that seems to make people feel better. Certainly, the treatment for this, you kind of go through your neonatal nasal airway obstruction protocol on airway management, and you can get kids started on some neosynephrine, dexamethasone drops, just medically. Surgically, you can do anything from dilation to a tracheostomy, depending on the severity, and I've done all of them. But really like to try to avoid a trach if possible. But this is a baby getting dilated here. This is a video of an approach to repairing the piriform aperture stenosis. And yeah, believe it or not, we actually did one, what was it, 2 weeks ago, Dr. Van Horn? So, like I said, every spring we see a couple of these. I don't know why. But so basically you want to do the sublabial approach, get down to the maxilla here. Of course, you want to make sure you're creating a little cuff to sew things back to. And you want to kind of get down in here and raise the mucosa. And generally you have this very prominent ridge of bone here. I like to use this just a 2 millimeter diamond otologic drill, and you kind of work from side to side. These things, they tend to bleed. So you have to use a lot of, putting some afrin pledgets on it. And, it's important to get a good injection, but you kind of have to switch from side to side. And then you're trying to open that coena, or not the coena, but the piriform aperture as much as you can. I like to try to get an 18 French in, just to make sure I can get an adequate size endotracheal tube stent in. Now, stents are controversial for this. Oh, the other reason I like to dilate in addition is to push over that inferior turbinate, because that tends to become an issue too. So stents are controversial. I generally put a stent in. Some people talk about doing stents for 3 to 4 weeks. This thing is all over the map as far as stents are concerned. But I like to put them in, but I only generally leave them in for about a week. Some people talk about suturing these stents to the columella or through the septum, but I did 2 of these in my fellowship, and one of them got a bad septal perforation. So I've just kind of been very skittish about suturing through the septum. So I kind of do this bridling technique around the back of the septum. I was using that umbilical tape before, but now I've just kind of evolved to using just a big suture through the back. That's what we did on our last one. And it doesn't go through anything. It just kind of bridles around the back to prevent the stents from coming out. And we're able to kind of just clip that at bedside very easily, remove the stents. And we're working on developing postoperative protocols for these children with piriform aperture stenosis, because those are all over the map too. And when you look at the literature, but we've worked with respiratory therapy just to get a protocol to keep these stents open, because one of the things you never read about in textbooks or papers is these stents will clog up very, very easily. And I've had to get through and ram a rigid suction through to unclog these stents before, and nobody ever tells you about that until you're kind of doing it on your own. And then but we've got a protocol worked out now that we'll probably be writing up just to describe how we do this here. And really, it's been a beautiful thing. All right, I think that's enough of that. Okay, so let me check our time. We've got about 8 minutes left. I want to be conscientious of whoever's following me, but I'm definitely not going to get through this talk. So anyway, this is a baby that was transferred from a private hospital here in town. Very similar symptoms of, the nasal congestion, difficulty feeding, some cyclical cyanosis. Was sent, right to our NICU. And look in the nose, and we see this in the nose. Okay, let me get back to my chat. Does anybody think they know what this is? Oh, somebody's saying something. Let's see. Okay, we've got a nasolacrimal cyst. We've got an encephalocele. Those are all very good thoughts. Dacrocystocele. Okay. Yes, that is what it is. So it's dacrocystocele intranasally. Just to kind of orient this, because it could be an encephalocele, and I have a video of an encephalocele later that we won't get to, but looks very similar to this. But just for orientation, which I should have done, this is the inferior turbinate right here. So, and this child had this bilaterally. It was more prominent on the left-hand side, but as you can see in the imaging that we got, because, you know, honestly, I wasn't sure that it was not an encephalocele either, so I wanted to confirm with that. But you can see clearly back there, there's some dilation of the nasal lacrimal duct associated with a cyst right at that location. So, you know, what happens with these? These are obstructions of the nasal lacrimal system. You have this proximal valve of Rosenmuller and the distal valve of Hassner. So it's basically failure of that distal valve to open up all the way, and then you get a collection of mucus and tears and whatnot that can form this, basically just blow up this water balloon, so to speak, there in the nose, pushing the inferior turbinate, medially causing nasal airway obstruction. And you can have this associated with some dacryocystitis, where babies will present with this kind of bluish, reddish swelling just kind of here at the medial canthus. And, you know, in general, you can kind of put some warm compresses on these and express them out and get things to, you know, you can see that there's, you know, something coming out of the tears here, which can help you with the differential diagnosis. But I always like to look in the nose with these, and usually we're getting together with pediatric ophthalmology to make sure they can probe through with these. We did a systematic review, just in general. I'm not going to go into detail, but you know, in general, we found that we get a little bit better success, fewer revisions if we combine these just procedures in general, the congenital nasal lacrimal duct obstruction with endoscopy with us. But this is probably gonna be the last thing I'm gonna show. So here's our cyst that we see here, kind of pushing that inferior turbinate immediately here. Oh, this may be the one video that I didn't get to edit all the way. Okay. So we're going to look at this thing for a long time. Oh, let me see here. I apologize for this. So here we're excising some mucosa. I like to use some otologic instruments. People have described using like a powered, you know, inferior turbinate blade to do this, and I've used that before too. But sometimes you just kind of pop the outside of it, and you got to get in here and remove a lot of this redundant mucosa. But you can see there's a wide open nasal lacrimal duct when we complete that. Let's see, I'm gonna stop that and go on, maybe. Okay. This is the encephalocele. Okay, we got some time. All right, so this is a 2-year-old sent to me by one of our friends in town who, the story was the kid put a bird seed in his nose and couldn't breathe through the nose. So the outside ENT looked in and said, whoa, there's this nasal mass. And turns out the history was over a period of several months, there was some worsening nasal airway obstruction on one side with some rhinorrhea. Let me show you this imaging here real quick. That's the CT scan. And yeah, you know, there it is right there. We've got a defect here. A surgeon that got the MRI, and lo and behold, meningoencephalocele was the diagnosis. I'm gonna skip. I'm just gonna show this video and end on this because no one wants to look at words. We'd rather look at videos. So again, you know, very similar looking to that dacryocysticeal on first glance. You know, it's hard to get a newborn baby or a 2-year-old, or even sometimes adult maybe for that matter, but to get a good look in the nose, to see what's going on, and distinguish, you know, where exactly does this come from. But you can kind of see that this thing has, it's not tracking under the inferior turbinate, it's tracking right up to kind of the cribriform area. So, and what this has done is it's it's expanded the mucosa. So you've got this covering of mucosa that's expanded, and then under it is the encephalocele itself. So what we're trying to do is get things back, incise the mucosa, get to the encephalocele, and it's really a lot of bipolaring, and then incising some mucosa just to make sure you can preserve as much as you can to kind of lay back down on the lateral nasal wall there, just so we're not getting too much scarring. But you just kind of systematically work back to the stalk of this thing. Oh, we got 1 minute. And so we're back to the stalk of this thing. And there's a small defect there. We're repairing it with some bone that we obtained from the middle turbinate. Put that thing up there, put a little middle turbinate mucosa flap up, or free graft up, excuse me, making sure that mucosal side is out. And voila, throw it to the ceiling and it sticks. And kid did well. Okay, it's 8:59. We have 1 minute for questions. Instrument you use for opening up the, yeah, so yeah, again, I apologize that video wasn't edited, but some people use kind of a powered, you know, the inferior turbinate blade. So it's got a much small, it's the one that you kind of stick in the, you know, submucosally, and you try to do a submucosal resection of the inferior turbinate. So it's that Medtronic one. You use that same one, and you can kind of excise that cyst there. Otherwise, you know, again, sometimes it pops and it's hard to see. And then what I'll do is just use some otologic instruments, using some small cups or some Bellucci scissors that are angled and that type of thing, just to make sure I'm able to get in there and remove all of the that mucosa. Okay, it's 9 o'clock. Thanks everyone for your attention, and enjoy the rest of your time. And maybe I can finish this up if people are interested at another time. But thank you so much.
Thanks so much, Ken. Really appreciate it.
Yeah.